We are live, sir. Please start the session.
Nitin?
Screen on sharing mode. Dr. Prashant, please confirm once my slides are visible.
Yes, sir. Your slides are
Thank
visible.
you. Dear all, good evening. I am Nitin, and on behalf of Mankind Pharma, I would like to welcome all of you for the today program. So today we have a program Trinity of COVID-19. For today's session, we do have Dr. Paul E Marik with us, Dr. Shashank Joshi, Dr. Suryakant, Dr. Arindam Kar, and Dr. Anup Kumar. So very good evening to all of you, sir, and welcome on the board. So before hand over this session for today, I would like take a couple of minutes of yours, sir, just briefing introduction about the company. Sir, in 1995, Mankind was established founded by Mr. R.C. Juneja, and Mankind is ranked 1 prescription-wise and ranked 4 value-wise. So we are having strong presence across prescription drug, OTC, and veterinary medicines. Here in Mankind, sir, our philosophy is just serving life, which is based on three pillars, that is quality, affordability, and availability. So we do have such strong presence across all the therapy like anti-infective, gastrointestinal, cardiovascular, nutraceutical, dermatological, ophthalmology, anti-allergy, and so on. So we do have, sir, our own R&D center, which is backed up by more than 350 scientists. And sir, our main core areas of clinical research and biopharmaceutics is clinical trials, new drug discovery research, biopharmaceutics, and advanced pharmacokinetic modeling and biostatics. With this, thank you for your continuous support, which is encouragement for us. Thank you so much, everyone. Dr. Prashant, over
Thank
to
you,
you.
Nitin. And, and it is my privilege to introduce you to this session's speaker, Dr. Paul E. Marik, is professor of medicine and chief division of pulmonary and critical care medicine, East Virginia Medical School, Norfolk, West Virginia, USA. Dr. Marik received his medical degree from University of Witwatersrand, Johannesburg, South Africa, then obtained Master of Medicine degree, Bachelor of Science degree in Pharmacology, so on. Dr. Marik did a critical care fellowship in London, Ontario, Canada, during which time he was admitted and fellow at the Hospital College of Physicians and Surgeons of Canada. Dr. Marik has worked in various teaching hospitals in the US in 1992, and he has been board certified internal medicine, critical care medicine, neurocritical care, and nutrition science. Dr. Marik has written over 500 peer-reviewed journal articles, 80 book chapters, and authored 4 critical care books. He has been cited more than 44,000 times in peer-reviewed publication and has an H-index of 98. He has delivered over 350 lectures at various international conferences and visiting professorships. So he has received numerous teaching awards, including the National Teacher of the Year Award by the American College of Physicians. And with this, I welcome Dr. Paul E. Marik to please, sir, start your session. Then I will introduce our panelists.
Thank you kindly for that introduction. So, obviously this is a very big topic. So I'm going to focus on some really important aspects of the clinical management of COVID. My talk should be about half an hour, and then that should give us plenty time for questions. I have, most importantly, no disclosures and no conflicts of interest. So a really important concept is you need to understand the disease to treat the disease. And unfortunately, I believe that there's been an enormous amount of misinformation about this disease. So part of my talk today will be to explore the pathophysiology of this disease. So firstly, we know that this virus is spread by droplets and aerosols. It binds to ACE2 receptors in the ciliated epithelium in the upper respiratory tract, where it replicates. We then get viral aspiration into the lung, and this sets the stage for the pulmonary phase. What's important to note that ACE2's expression is highest in the upper airways, as is infectivity, and this is not always appreciated. So when one is exposed to the virus, there's a dynamics which depends upon the viral load and the host's immune response, particularly the interferon response. So with a low viral load and a brisk interferon response, the host can control the disease and it becomes mild. However, in patients who have a high viral load, in older patients, there is a delayed interferon response, and one gets very high viral titers, and this results in severe disease. Probably the most important concept to recognize is that COVID-19 progresses through a number of stages, and the treatment is very specific, stage dependent. So this scheme is with the original isolate. So with some of the variants, this time course may be somewhat accelerated. So anyway, we have the incubation period, which has a mean of about 5 days. We note that viral replication peaks prior to the onset of symptoms. This is important and distinguishes SARS-CoV-2 from SARS and MERS. Then we have the symptomatic phase, fever, malaise, cough, headache. We note that viral replication decreases during this phase. Then we have about 20% of patients in the symptomatic phase who will go on to the pulmonary phase. And this, as we will see, is a profound immune dysregulation, predominantly mediated by macrophages in response to viral debris. And then this can continue to the late pulmonary phase. So again, this is the time course. This is viral isolation. This is when the patient is infectious. So we can see that after about 10 days, 15 days, we can no longer isolate virus from the respiratory tract. Patients are infectious during this period, the incubation period, the early symptomatic period. What's important to recognize is that nasopharyngeal swab PCRs remain positive for a prolonged period of time. You can see up to about 5 weeks, at which time there's no longer active viral replication. And this is important for people to recognize. So the fact that the PCR is positive does not mean the patient is infectious or has active viral replication. You can see antibody response, IgG, IgM, starts about 10, 14 days, almost at the same time as the virus disappears. And probably this reflects the development of adaptive immunity. So this is the stages of COVID in terms of symptoms. This is with the original SARS-CoV-2. It may, as I said, be somewhat shortened with the variants. We have fever for about 10 days, cough for about 18 days, and then this is when the pulmonary phase begins. So this is important that patients are symptomatic. They may then improve, and then about day 7, they start developing a shortness of breath, come to the ICU in about day 10, and ventilation. The lower hatch reflects patients who died. So as we know, this is a profoundly heterogeneous disease. There's no single typical patient, and that means that treatment and approach must be individualized. And there are a whole host of factors that determine the clinical course. It seems inoculum size is very important, hence the need for masks, the ability, the ACE2 expression, temperance expression, and then, as we know, age, sex, obesity, race, immunotypes, vitamin D status, comorbidities, and other factors. So it's a highly heterogeneous disease. From a clinical point of view, it's really important to follow certain biomarkers which give you an index of how severe the patient is and their course. The D-dimer, lymphocyte count, IL-6 perhaps, and serum ferritin are really important. This was a study we did looking at outcomes, and we found that age and CRP were the best predictors of outcome. This is an important study, and there are multiple studies which reflect this. So in this study, they looked for culturable live virus, and this is indicated by these red dots. This scale is the PCR cycle threshold. The lower the threshold, the higher the titer. So what you see is those patients who have positive culturable virus have much higher titers of virus, and then after 10 days, patients no longer have culturable virus. This is exceedingly important in understanding this disease. So although patients may remain PCR positive, and in sometimes up to 70 days, they do not have live culturable virus, the PCR is picking up RNA fragments. So in terms of the pathophysiology of COVID-19, this is important. We've just finished writing a review. Essentially, COVID pulmonary phase is a macrophage activation syndrome. It's characterized by profound infiltration of the alveolus by macrophages, activation of macrophages, and a hyperinflammatory state. The second important component is a complement-mediated endotheliitis with activation of clotting and platelet-rich thrombi. And it seems that there are increased expression of ACE2 receptors on the microcirculation in the lung, brain, and fatty tissue. So these are the targets. As a result of platelet thrombi, we get very high levels of circulating serotonin. Serotonin causes arterial vasoconstriction, VQ mismatch. In addition, as we know, patients develop autoantibodies, mast cell activation, ACE2 deficiency, and T cell dysfunction. This is shown schematically on this diagram in progress. SARS-CoV-2 infects ACE2 cells, alveolar macrophages, produces all these chemokines and cytokines, but mainly these chemokines, which then act as attractants for monocytes. So we get a profound monocyte infiltration into the alveolus. These then mature into M1 macrophages. These macrophages produce a whole host of inflammatory mediators. We do note that we do get some infiltration of neutrophils, but this is predominantly a macrophage disease. Part of the problem is the macrophages do not kill the neutrophils, and this results in netosis. So this is the one arm. The second arm is that the SARS-CoV-2 binds to and infiltrates the endothelium. One gets complement-mediated endotheliitis, platelet activation, platelet-rich thrombi, and release of serotonin. So this kind of outlines the basic pathophysiology. Please note this is an organizing pneumonia. This is not ARDS. So as we see the progression of the pulmonary phase, the initial stage with macrophages, release of chemokines, these chemokines then attract monocytes and macrophages, which then produce pro-inflammatory mediators, and then this leads to the later stage. So this is a very good clinico-pathological paper from Mount Sinai. They looked at clinical and autopsy data. They concluded that this disease is characterized by endothelial damage, an imbalance of both innate and adaptive immune responses with aberrant macrophage activation. Again, very important, aberrant macrophage activation, which plays a central role in the pathogenesis of COVID-19 disease. This is what one gets in organizing pneumonia. In addition, this paper in New England Journal showing the endotheliitis, thrombosis, and angiogenesis. So these are the two major components of COVID-19, organizing pneumonia and this vascular endotheliitis. It's most important to emphasize this is not ARDS. In no way, shape, or fashion does COVID-19 pneumonia resemble ARDS. And treating these patients as if they had ARDS is profoundly dangerous. So this is the typical CT progression of COVID pneumonia, and you can see that a typical ARDS on CAT scan, as described by Gattinoni, is completely different to this disease, which begins with these peripheral airspace ground glass opacifications. They're peripheral, they're patchy, they're bilateral. We then get progression of the ground glass. We then get airspace consolidation. We get further airspace consolidation, bronchiectasis, and you can see we get some crazy paving and progression to fibrosis. No way in heck does ARDS do this. It's a complete mystery that people consider this ARDS. Both clinically, pathologically, histologically, this is not ARDS. So in terms of the management, which we'll go through quickly, obviously this is a complicated disease. This table is based on randomized controlled trials looking at studies which showed a benefit, no benefit or harm based on the stage of the disease, pre-exposure, post-exposure, symptomatic phase, and the pulmonary inflammatory phase. Please note that there are really only 3 drugs. There are only 3 drugs which have shown benefit in this disease. For 2 of them, they're really very phase specific. So we know corticosteroids are very useful in the pulmonary inflammatory phase, which we'll talk about. In the symptomatic phase, they cause harm. As we know from the recently published studies, full anticoagulation of benefit in hospitalized patients. In ICU patients, not so much. So we'll just recommend intermediate or high dose prophylaxis. In terms of ivermectin, randomized placebo-controlled trials show the benefit of ivermectin across the board. And, we'll talk about this in a little detail because this is really important. But I think this slide is important because clearly it illustrates those drugs which work and those drugs which do not work. So then combining the therapeutic interventions with the phase of the disease, clearly you want to use antiviral therapy in the early phase. It's completely preposterous to start using antiviral therapies in the pulmonary phase when the virus is dead, because you cannot kill something that's already dead. And therefore, the anti-inflammatory therapy has its most important role in the inflammatory phase, not in the early phase where it will promote viral replication. Obviously, as we said, ivermectin across the board, and then a number of other molecules or pharmacologic agents which seem to have benefit again across the board. So what does the NIH say? Well, it's kind of pitiful. If you're not hospitalized, they say nothing. If you're hospitalized and don't require oxygen, there's no treatment. If you're hospitalized and require oxygen, they talk about remdesivir and dexamethasone. As we know, remdesivir does not reduce mortality. So how did we come up with our Math Plus protocol? Well, it really was an extension of our HAT protocol, which we developed for the treatment of septic shock. Obviously, there's a similar degree of immune dysregulation with COVID, so we adapted the HAT protocol for COVID-19 pneumonia. And therefore, we came up with the Math Plus protocol. The most important core components are intravenous methylprednisolone and heparin. Those are the most important. Ascorbic acid and thiamine have adjunctive roles, again, as well as these other medications listed here. So the rationale for the Math Plus protocol is based on the 2 factors which we outlined at the beginning. This is a disease characterized by hyperinflammation, macrophage activation. This is a pulmonary macrophage activation disease, and then hypercoagulability. So therefore follows from this that the treatment must be anti-inflammatory, anticoagulant, as well as drugs which decrease or block serotonin. So this is the full Math Plus protocol. I can't go through the entire protocol, but this is available on our website at www.flccc, that's flccc.net. It goes through the entire protocol. Briefly, methylprednisolone, ascorbic acid, thiamine, heparin, ivermectin, fluvoxamine, cyproheptadine, antiandrogen therapy, vitamin D, atorvastatin, melatonin, zinc, and famotidine. Now, obviously, you'll see that the treatment really depends on the severity of illness and the stage of the disease. So we need to come to corticosteroids because these are really a key component of the hospital treatment phase. It's really important to emphasize the drug of choice is methylprednisolone, not dexamethasone, for multiple reasons which we can briefly review. The drug of choice for the pulmonary phase is methylprednisolone. So corticosteroids are really potent anti-inflammatory drugs. They act on multiple cells via multiple pathways to decrease inflammation. This is a very important study, which is a genomic study specific for SARS-CoV-2. They looked at alveolar cells, alteration of gene expression in alveolar cells exposed to SARS-CoV-2. They then looked at those medications which specifically reversed those changes induced by SARS-CoV-2. So this is a genomic study looking at the genomic effects of steroids. You can see the drug with the highest hit was methylprednisolone. Dexamethasone was much lower on the list. So these drugs have different genomic effects. In addition, one needs to look at the pharmacology and pharmacokinetics. Methylprednisolone, because of the methyl group, penetrates significantly into the lung. So we have much greater pharmacological levels in the lung and much better pharmacokinetics than prednisolone or dexamethasone. So this is important. Methylprednisolone has greater genomic effects, has greater non-genomic effects, and has much higher concentrations in the lung. So when one talks about corticosteroid for COVID pneumonia, what's important is the drug, the dose, the timing, the duration, and the taper. So we know about the recovery study, which used 6 milligrams of dexamethasone. This was so they used 6 milligrams of dexamethasone for up to 10 days. The median was 7 days. That's equivalent to about 30 milligrams of methylprednisolone. So as we'll see, they used the wrong drug in the wrong dose for the wrong duration. Nevertheless, they did demonstrate that corticosteroids do have a clinical benefit, decrease the mortality in patients on invasive ventilation and those on oxygen. But still note, even in the dexamethasone group, a significant mortality, 20%. So that although it reduces the mortality, it was still substantial. And we know with further studies that the results are significantly better with methylprednisolone, as we'll see. What they did show, which was important, was that in the pulmonary phase, corticosteroids obviously reduce mortality. However, in the non-pulmonary phase, those who require oxygen, there was a tend towards harm. So again, treatment is very phase specific. Corticosteroids should be used early in the pulmonary phase. So this is a table of the number needed to treat with a number of studies comparing methylprednisolone to dexamethasone to hydrocortisone. And you can see the number needed to treat to save one life is significantly lower with methylprednisolone than with dexamethasone. So we have genomic, non-genomic, pharmacokinetic, and clinical data all strongly supporting methylprednisolone as the drug of choice. And what we do is we base the dosing on the severity of illness, the CT scan, degree of hypoxia. So in the patients with the mildest disease, we give 80 milligram bolus, then 40 Q12. As the patients present later with more severe illness, we increase the dose. It's really important to recognize. So it needs to be individualized according to severity of illness. What's also important is treatment should be started early. There's no benefit from delaying treatment. Then the steroids are tapered slowly over 2 weeks, guided by clinical response, CRP, and chest imaging. So the issue with steroids is you whack them with steroids, you hit them early, you hit them hard, and if you do it that way, you'll be able to wean your steroids pretty quickly. Next, we're going to focus on ivermectin. So in 2015, William Campbell and Satoshi Omura were awarded the Nobel Prize for their 1975 discovery of ivermectin, first used in humans in 1987. Ivermectin binds to glutamate-gated chloride channels in invertebrate parasites and worms, and paralyzes the worm. It's highly lipophilic, rapidly absorbed, reasonably long half-life. Really important to note, it's on the World Health Organization list of essential medicines. It's on the WHO's list of essential medicines, which becomes important. Over the past 3 decades, approximately 3.7 billion, that's a B, billion doses of ivermectin have been distributed worldwide. As we'll see, it is one of the safest medications known to mankind. It's broad-spectrum antiparasitic, antiviral. In addition, remarkably, it has potent anti-inflammatory and immunologically modulating effects. It's very safe and well tolerated, even up to 10 times the recommended dose. The usual dose is 200 mics per kilo. It's been dosed up to 2,000 with very minor side effects, usually related to death of the parasite rather than the drug. So how does it work? It works by multiple pathways. Probably the most important is it binds to the nuclear important pathway, preventing viral products getting into the nucleus. So this binds to the important pathway. However, it also binds to the RNA-dependent RNA polymerase, the spike protein, and the proteases. So it seems to have broad-spectrum antiviral activity against SARS-CoV-2. However, it has also activity against dengue, Zika virus, influenza virus, HIV virus, because it targets these non-specific viral pathways. So in terms of ivermectin, we can see 56 clinical trials. Of these, 28 are randomized. So this is what the ivory tower wants, 28 randomized controlled trials. There's only one study which was negative, and this was a profoundly bad study. From these studies, 85% improvement in the prophylaxis studies, 78% improvement in early treatment, 46% in late treatment, 74% reduction in mortality. You can see the profound risk ratio for these studies. So ivermectin has been proven conclusively to have dramatic effects at all stages of this disease. Again, this is looking at the mortality, looking at the observational and randomized controlled trials, all showing pretty significant effect. When one looks at prophylaxis, and this is really important because ivermectin has a role in prophylaxis and really fills the gap between the need for vaccination. You can see a profound reduction in the risk of symptomatic infections in those who've been prophylaxed with ivermectin. So what does the WHO say? In spite of all this data, they say they do not recommend the use of ivermectin. They say it has no proven beneficial effects on mortality, ventilation, hospital admission, duration of hospitalization, and may increase the risk of side effects. As we'll see, this is completely bogus and completely dishonest from the data we have just presented. So why this dishonesty? And obviously, dishonesty has serious consequences. And the reason is quite simple. The emergency use authorization for all the COVID-19 vaccines is based on the principle there's no viable alternative therapy. If ivermectin was approved, the EUA for every single vaccine would be needed to be terminated. And actually, this is the document from the FDA guidance on EUAs. And again, you see, for the FDA to issue an EUA, there must be no adequate, approved, or an available alternative to the candidate product. So this is from the FDA themselves. So this appears to be the reason that the WHO, the NIH, the CDC, the FDA are so profoundly dishonest. So moving on to anticoagulation with heparin, it's important to note that heparin is not only an anticoagulant, but has a whole host of other potential benefits for this disease. It inhibits viral entry. It inhibits heparinase, which breaks down the glycocalyx. It neutralizes chemokines and cytokines, interferes with leukocyte trafficking. Obviously, it's an anticoagulant. And as we said, NETosis is an important problem in COVID-19, and heparin prevents NETosis. So this is summary of data from the ATC REMAP CAP and ACTIVE study, in which they enrolled close to 3,000 patients, 1,700 with moderate, 1,100 with severe. What they showed that full anticoagulation, regardless of D-dimer in the moderate group, reduced mortality. However, there was no mortality benefit in the severe group. They've now just published their data in the non-critically ill people, and you can see in terms of organ support-free days, a significant benefit of anticoagulation regardless of your D-dimer level. In terms of ICU patients, what we suggest is high-dose prophylaxis, which appears to be the optimal approach in reducing mortality. So as we said, what we focus on with the Meth Plus was the late treatment, but we obviously realized that to have the greatest impact, we need to treat these people early, before they really become sick and go to hospital, and in terms of pre and post exposure prophylaxis. So therefore, we developed the IMAS protocol for prophylaxis against COVID based on ivermectin, and then early outpatient treatment. It obviously makes sense. You want to treat people as soon as they become symptomatic. That has really two important benefits. One, it prevents them progressing to the point they go to hospital. So it decongests hospital, and these patients have a better outcome. And also it limits transmission of this disease. So we strongly, we've shifted from the hospital phase to the outpatient phase and the early at-home treatment phase, which we think is critical in controlling this disease. In addition, we've come up with the IMAS protocol. So this is a protocol for the mass distribution of ivermectin in those areas that which have severe and uncontrolled COVID. So what you do is you provide ivermectin to the entire population of people, and there is data that this significantly reduces the risk of COVID. And with that, I thank you. I went through that really quickly, but I think it will give time for questions. So again, thank you for inviting me to speak today.
Thank you, Dr. Paul. Now let me introduce you to our esteemed guests of panelists. First, let me invite Professor Shashank Joshi, sir, who is a Padma Shri awardee and endocrinologist at Joshi Clinic, Lilavati Hospital and Bhatia Hospital. He is also the chairperson for International Diabetes Federation, Southeast Asia, and Dean, Indian College of Physicians. Our second panelist of tonight is Professor Suryakant, sir, who is head of Department of Respiratory Medicine, King George Medical University, Lucknow, and also member of Institute and governing body AIMS, Patna, and member Executive Council, UP Medical University, Saifai, Etawah. Welcome, sir. Our third panelist is Dr. Anup Kumar, sir, who is Chief Critical Care Medicine at Baby Memorial Hospital, Kerala. He is member of State Government's Medical Advisory Panel on COVID Management and active member of Indian Society of Critical Care Medicine and European Society of Intensive Care Medicine. Welcome, sir. Our fourth panelist of tonight is Dr. Arindam Kar, sir, who is Chief Intensivist and at Department of Critical Care Medicine at Sir H.N. Reliance Foundation Hospital, Mumbai. He is also National General Secretary for ISCCM and former Director and HOD C.K. Birla Group of Hospital Institute of Critical Care. Welcome, sir. Now, I would request our panelists to have a formal comment on Dr. Paul Marik's presentation, sir. So let me start with Dr. Joshi, sir.
So, Paul, that was a fantastic talk as usual. Unusual. There are a couple of things about SARS-CoV-2 or COVID. One is it's predictably unpredictable. So, that is something which is a common thread. But within that unpredictability, you're trying to make some good biological possibilities, good therapeutic possibilities, and good treatment strategies. And I think in a very nice and illustrative way, you have put out what works and what does not work. The COVID controversies will continue because every pandemic has controversies, and that keeps everything going. But a couple of things is that 80% of COVID will recover independent whether you treat or you don't. It's those 20% which are likely to deteriorate. And I think catching them is the key. For example, in India, we have limitations of resources. So I just want to add to what you said, Paul, is if you do a simple complete blood count and look at the red cell width, and if it's more than 14.5, the patient is likely to deteriorate. If there is a progressive lymphopenia or a thrombocytopenia coming up, the patient is likely to deteriorate. On the complete blood count, if there is a neutrophil to lymphocyte ratio which is more than 3.3, you're likely to deteriorate. So just by a simple complete blood count, which is accessible to the remotest corner in rural India, you're likely to deteriorate. The second thing is the CRP. If the CRP keeps doubling up very quick and fast, you're likely to deteriorate. One of the earliest biomarkers is ferritin, and in a very nice way, you have illustrated the macrophage activation syndrome and the serotonin component. So ferritin is a good biomarker to pick up early, apart from, of course, LTH, D-dimer, and so on and so forth. So I think, one thing we know about COVID treatment is less is more. So the less over therapeutic you get and the earlier you hit, it's the right timing or the right drug at the right moment. So that's the key. And I think that's where Paul is bang on. His protocols are widely followed across the world. But the evidence base, will be, always be a scope for concern and controversy. So we need to take things as they go in the evidence-based era. So a couple of insights which you gave us about the thromboembolic and inflammatory potential. So it's a thromboinflammatory disease. So I think it's not the virus which really destroys us, but it's the immune inflammation and the thrombocoagulal parameters, which really are the sinister killers, and mortality is 1 to 2%. But it's early recognition which is the key, and I think that's very very vital. Of course, steroids are life-saving if used at the right time in the right patients. If you use them too early, they can be detrimental. Using them too late may not be useful. Using them too much, Paul, you may be surprised, but my good friends are here. Surya is here, Anup is here, Arindam is here. They'll agree with me that we have now generated a new problem of a mucor, mycosis here. So that's another challenge. So we need to really rationalize it. Of course, diabetes is a big comorbidity which drives a lot of it. India has the second largest population of diabetes in the world. It has one of the highest populations of hypertension in the world. So there are those two major comorbidities. But we clearly have seen two waves. The first wave was different from the second wave. Second wave had a variant of concern, which was rapidly spreading. It was a cluster spreading variant. It recovered rapidly too. But if the access to care was denied or if the right treatment was denied, there was case fatality. And we saw a younger cohort, a decade or two younger cohort getting afflicted without comorbidities. So the variant of concern and the 617.2, 6.7.1 and 6.7.3 are areas of research. So we still need a lot of genomics, and you're absolutely right. I love your steroid slides of the genomic trees and how you illustrated it so elegantly and in such an elegant way. And we also are seeing that the variants may have immune escape phenomena, which is also seen. And we still need to go beyond vaccine and think out of the box. So Paul, a wonderful talk. You really have been out of the box in many ways. And what you have emphasized in your support protocol is the value of nutrition. But there have been, the good and bad. You didn't highlight too much on vitamin D. I'm a big proponent of vitamin D. But I think vitamin D has a clear immunomodulatory role. It has data to support it. So as an endocrinologist, I would definitely like to pitch in for vitamin D, much bigger than the other nutrients which you pitched. Of course, you said 4,000 IU. In India, we use another protocol, which is we use 60K daily for 3 days sometimes, because then that saturates the vitamin D levels quick and fast. So that's what we do sometimes, because they sometimes come with very low vitamin D. Of course, whether it works or not, whether there is evidence base or not, most of the things are still in research mode. It's a new disease. It's a disease with not more than not even 2 years old, and we still are trying to say that, as I said, it's predictably unpredictable. But what was true yesterday may not be true tomorrow. So I think, Paul, you have been a little, path breaking in many ways, and some of your insights are very valuable. Particularly your pathophysiological insights were valuable, and I'm sure my worthy colleagues will definitely add some more light to their pearls of wisdom, and then we can have a night's discussion on this.
Yeah, so thank you. I agree with you. It's the right drug at the right time and the right dose. So timing is important. So you can't have a one-fits-all strategy. In terms of vitamin D, I absolutely agree with you. It's such a simple intervention. We know how many elderly people, people of color, people more north are vitamin D deficient. And, vitamin D plays such an important role in this disease. It's unfathomable to me why the health authorities haven't promoted vitamin D. It's such a simple intervention, and I think it can have a major impact. So I do agree with you completely.
Thank you, sir. Now I would request Dr. Suryakant, sir, to please have your comment, sir.
Fantastic, Paul. It was very simple, it was crystal clear and very precise, I would say. And two things I would like to comment. First, regarding your pathophysiological comments, that the viral replication phase, it reaches to the maximum, rather it is started decline when you have developed these symptoms. I think that's a very wonderful thing which we have learned today, that most of us, they are having opinion that when symptoms are on, probably virus is in replication phase. But you said that first symptom when appear, probably replication phase start declining. So that's a wonderful thing. The second thing is that you have given the importance, the clear-cut picture of the ivermectin. I am Dr. Suryakant from the Lucknow city, which is the capital of largest state of India, that is Uttar Pradesh. Our state population is 240 million. So it's not a state, it's a roughly more than country. So, and this, our state is the first state in India which started its government protocol with ivermectin and doxycycline. And we have also published a white paper. I think, I don't know whether you are aware or not, we published white paper. We 18 pulmonology experts from India, including me, we published a white paper on ivermectin first time in July 2020. And since then, of course, based on that white paper and other literature, the UP government came with the first, of course, governmental protocol for the mild to moderate cases of COVID-19 in 2020. The one question to you, Dr. Paul. Professor Paul, one of my friend, a lot of other colleagues, they are now thinking and they are using this ivermectin along with steroid for the controlling the cytokine storm. I am not aware of because ivermectin is known for, yes, it should be used in viral application phase. It reduces the number of viral copies. That is proven in vitro also, and that is, of course, efficacy in vivo also. But what is your comment that ivermectin can be of help during cytokine storm also? Dr. Paul, please.
Yeah, so that's a really good question. And that's why I think ivermectin was designed for this pandemic, because not only is it antiviral, which we know, but also is anti-inflammatory. It inhibits NF-kappa B. It prevents NF-kappa B getting into the nucleus and transcribing all these inflammatory mediators. So in addition to being antiviral, it's a potent anti-inflammatory drug. And we know this from Dr. Raj's study in Florida, where he showed that critically ill people who received ivermectin had a dramatic reduction in mortality together with steroids. So it seems that it needs to be together with steroids. So this is a wonderful drug. It seems to work across all the phases of the disease. Potent anti-inflammatory, antiviral. I think its most important properties are antiviral. But in addition, it does have anti-inflammatory properties. Very good question. Thank you. And
Thank you.
what you guys are doing in India is wonderful. I think everybody you need to put ivermectin in the drinking water.
Yeah. Sir, Goa is the first state in India which have issued a government order for the mass prophylaxis for the prevention of COVID-19. So it is the first state in India. So I think I can also foresee the use of mass prophylaxis. What's your comments regarding the mass prophylaxis?
Yeah, so I think what you want to do is, obviously vaccinations work, but it takes a long time to get neutralizing antibodies. And in that stopgap, we think ivermectin is very effective in preventing disease. We know the studies done in Argentina and Chile that ivermectin is profoundly protective against SARS-CoV-2. So I think there's an enormous role for just mass prophylaxis of the population where you have a high incidence of SARS-CoV-2. Yes.
Thank you, sir. Now I would request Dr. Anup Kumar, sir. Sir, please, sir, your comments.
Sir, actually, I was following your protocol from initial days onwards, especially on high dose steroid. So even we have adapted that high dose steroid in the first wave, and even now. And we also had an excellent result with high dose steroid rather than using only 6 milligram of dexamethasone as per the trials. And another thing, regarding your high dose vitamin C, that also we were trying in sicker patients. I don't know whether it is really effective or not, but some group of patients it was really effective. And definitely the melatonin part, I've not seen any other protocol where the melatonin was included, but I've seen in your protocol where high dose melatonin was included, and we were trying it for outpatients and as well as the patients with minimal symptoms and even the patients with who are very sick. So I would like to hear from you regarding high dose vitamin C and melatonin as well.
Yeah, so you asked two good questions. I think the core treatment of corticosteroids. So unlike sepsis, where vitamin C has an important role, I think the vitamin C has an adjunctive role together with steroids. And we believe that you need to use higher doses. So I think in COVID, one needs to use higher doses. We've been more recently in very sick people using 25 grams Q12. So, I think that there's no single magic bullet. I think all of these drugs work together. I think in COVID, you need higher doses of vitamin C, and I think it works together with corticosteroids. The melatonin is truly a fascinating molecule. It's a very potent anti-inflammatory. It also resets the metabolism of macrophages. So with COVID, macrophages tend to go down the glycolytic pathway rather than oxidative metabolism. Melatonin resets that. And there are two really important studies which have demonstrated strongly the benefit of melatonin. There was a study out of the Cleveland Clinic that showed that those people taking melatonin had a significantly lower risk of getting COVID than those who weren't, particularly those people of color. So it seems to have an important role. Secondly, there was a study out in New York City showing that those patients on melatonin had a significantly reduced risk of death. The p-value was like p.0000001. It was so profoundly positive. In the US, melatonin is very cheap and available over the counter. So I do know in some other countries it's less available and less accessible. But if it's available, it's a very safe drug that seems to have particular utility in COVID.
Thank you, sir. Now I may request Dr. Arindam, sir, to have, sir, your comment, sir.
Hello, Marik, sir.
Hey.
I hope you are doing good by yourself. A little bit of comment, and then I will put only one question because everyone is bombarding with you with questions, right? So I think this is a very nice terminology that you have come up with, that this is more of a pulmonary macrophage activation syndrome. So in short, people who know about MAST would definitely in that one terminology will understand the pathophysiology that is happening in the lung itself, right? And We can also, in your lecture, you have very clearly demonstrated that there are two distinct pathology happening: an epithelial injury and endothelial injury. So if you target two separate ways, I think that might minimize the mortality itself. Secondly, a lot of time after almost 2 years now, most of the critical care physicians, pulmonologists, internists still are yet to accept the fact that you have to have a higher dose of steroids when it is not working. So I think India has now started two trials on pulse dose therapy of methylprednisolone, and rather than escalating approach, sir, I fully agree with you. I have been following that rather a de-escalation strategy would be much more useful when you are dealing with the severe cytokine storm. And it has been very clear, and I think people will benefit from your lecture itself, then dexamethasone, just by blindly following a recovery trial, it doesn't make sense, because methylprednisolone has a much better pulmonological penetration in terms of also your alveolar fluid concentration also. Regarding, I think Shashank sir also told about a predictive scoring or predictive, so say, a lot of studies have been done in, we are also doing in Mumbai, whether we can have a composite predictive scoring where we can combine the symptoms, the signs, the biomarker levels and all others. But in a country like India, where you have a heterogeneity of access to healthcare, I think one of the major sign is a non-resolution of symptoms beyond first week. I think that would be particularly the cough and the fever itself. That should indicate that something is wrong and this patient is going towards a little pulmonary phase itself, even if you cannot afford a lot of biomarkers in so many people itself. And regarding, I'm very what would I say, sir, is that you very clearly told about the dishonesty of authorities, right? And we all know that how things have changed. But also in India, there is a new concept that has come. It's called evidence-based naturopathy. I hope in US you don't have to face that, right? We are seeing a lot of evidence-based naturopathy now, and we have a conflict of modern medicine as well as traditional medicine. Thank God that you don't have to face that sort of situation in US. But I am a little skeptical about evidence-based medicine, because practically every now and then we have a contradictions of the evidences that is happening. For example, with all due respect to you, sir, when you are presenting something, you will come up with a lot of good things about ivermectin, vitamin D, and melatonin. And the very next day, if we have someone as good as you, sir, he will contradict a lot of things. So we, in this era of information flowing in from every direction, we are actually flooded with a contradiction of information itself. So we don't know what to accept and not to. So that part is also important for us to select which information has to be eventually imbibed and put into. Definitely, I will take yours, sir. The math
So
protocol.
can I answer that question? I think the point you raised is so important, because there's just so much information and often it's contradictory. So I think the clinician has to look at the data, balance the data, and look at the source of the data. Because I think that one of the biggest problems of this pandemic has been this misinformation and this enormous amount of information. So, what you say is very true. I think, you have to think about the disease. You have to think about the source of the data and see what makes the most sense to you. And we have to, I think it's really important as a world medical togetherness to figure out what is true and what isn't true. And obviously, there are going to be various degrees of truth, but there's also a lot of nonsense. So we have to distill the nonsense and try and find some balance. But what you say is just so true.
And the last question, sir, can in near future we have some sort of genomic or genotypic markers or identification to preempt that which patient is or which person is going to have a severe disease?
Yeah, so I think you ask an interesting question. I think it's based on so many factors. I think it's the age, it's their sex, it's their comorbidities, it's their inoculum load, it's their basic underlying nutrition. I think there's so many factors. Now, maybe what you say about symptoms is really important. So if patients remain short of breath or symptomatic for more than 5 or 6 days, there's a problem. You don't need any fancy test to tell you that patient has a problem. So, I think it's a very complicated disease with so many different modulating factors. I think that it's unlikely we're going to have a single test which will answer this. I think you've got to put, the context of the particular patient. And also, it also depends upon, where your situation is, what country, what region. So I think there's no simple answer, but I think obviously what you say is just being a doctor, being a clinician, looking at your patient. And there's no question that a patient who's symptomatic for more than 5 days, they're heading for a bad course.
Yes. I think Prashant, I'm done. You can resume.
Thank you, sir. Thank you for the wonderful discussion. Now, if with your permission, can we move towards our Q&A session, sir?
Sure.
Sure. So, sir, I will ask these questions. I will put forward for in front of our panelists. And Dr. Paul, wherever you feel you can comment. I mean, in any of the questions, sir.
Sure.
So, sir, let me ask the first question with Dr. Shashank, sir. Sir, you mentioned about vitamin D3 role. So, actually, our audience wants to understand more about role of vitamin D3 higher doses in COVID-19, sir. How it can be given, or what are the side effects, or what are the precautions we should take?
So two things, what everybody was alluding to is there is a infodemic, which Arindam was saying in COVID times, and there is also a case demic. So two things, vitamin D, you must keep your vitamin D levels above 40 or 50 or 60. The higher you keep, better is the immunomodulatory potential of vitamin D. See, vitamin D is not just an ordinary vitamin; it's also an endocrine, hormone which regulates. There are vitamin D receptors on every cell of our body, which upregulate and make the cell more robust. It's an immune regulator. It's an immune modulator, and therefore, and you know that we have the Indian paradox, which means despite of plenty of sunlight, a large part of the Indian population is vitamin D deficient. Almost 60 to 80% of our population is vitamin D deficient, and therefore making vitamin D sufficient early. And that's where this is the, just like Dr. Paul has the MAT protocol, there is a MAT protocol for vitamin D, which gives bolus vitamin D 60,000 units daily for 3 days. So it saturates the vitamin D levels, because sometimes you may even take time to get the vitamin D levels. Otherwise, if you are normally also, you should be consuming around 2000 IU of vitamin D every day. The challenge is that in the Western world, like US, Europe, our milk is fortified with calcium and vitamin D. But in India, our milk is not fortified, or milk products are not fortified with vitamin D and calcium. So obviously we have a challenge. Also, the ability of people to go in sun has come down dramatically. It depends on the UV angle. There are many other factors. We also know the melanin in the Indian skin works like a sunscreen. So these are areas which, as an endocrinologist, we have worked in the past. So, and vitamin D not just has a role in reducing viral infections, viral load, and immune modulation, but it overall has a very, very useful role in health in general, not just in cardiometabolic diseases or infectious diseases or lung diseases. It definitely has a pleiotropic role. So I think having a U vitamin D level always is useful, whether it is an acute setup or a chronic setup. But you see, vitamin D is a fat soluble vitamin, and therefore if it goes in excess, there's a fear that can it cause vitamin D toxicity. That's very rare. If you use industrial doses of vitamin D over a very long period of time, occasionally you can get a D toxicity where you might have some renal damage. But we are here looking at acute condition, which is having a lifespan of 3 weeks, and the post-COVID syndrome, which has a lifespan of 3 months. The other thing which I want to tell you is, in the long COVID or the post-COVID syndrome, maintaining vitamin D levels between 60 or 40 to 60 clearly improves the quality of life, right? Where from cognition to mental health to physical health, vitamin D has a clear role in that. And there is very good published literature in the cellular space, because see, evidence-based medicine is not only about clinical RCTs. In the cellular space, in the clinical space, and in the RCT space, most of the literature is already there in non-COVID space. COVID space also, there is literature from the critical care space, where maintaining vitamin D levels have been useful, and there has been data which has been generated from India. So I'm a firm believer that D is an immunomodulator. It has its own standalone adjuvant role in having a disease modifying potential, and therefore it doesn't hurt having an adequate vitamin D or a sufficient vitamin D on board. And most of our ICUs have facilities to do a quick D check and replenish them with D if the patient is in the hospital or in the ICU. And even in the home care model and in the post-COVID model, having sufficient D on board is always going to be useful for cells because it's like a lifeline for the cells. And I firmly believe in it.
Yeah, I must concur 100% with Dr. Joshi. I really do agree with him 100%. And I think to emphasize that the earlier you use vitamin D, the better. Once the patients come to the ICU, I think you've lost that window and vitamin D becomes less effective. So upfront prophylaxis is really important, particularly in people at risk, elderly people, obese people, people who don't get out. And in fact, that's why in our prophylaxis, our IMAS protocol, we have ivermectin and vitamin D, because we believe those are the two most important measures to prevent COVID-19. And I think, vitamin D is very cheap, relatively speaking. And, it's a pity that your milk products aren't fortified, but I think the bottom line is that every single person needs to fortify themselves with vitamin D.
Thank you, sir. Sir, now let me ask next question with Dr. Surekant, sir. Sir, you have been a very vivid supporter of ivermectin, and sir, there is the concept of repurposing the drugs. So, of course, sir, ivermectin, like say. So, sir, our audience would like to understand more about this. Why we are doing repurposing of these drugs, and how, sir, ivermectin can be utilized in COVID patient, and sir, what can be the ideal dose schedule, sir?
Okay. Thank you, Prashant. Actually, I am the great supporter of ivermectin. And of course, my theory, my philosophy, my concept, I think has been endorsed by Dr. Paul just right now. So I'm now grateful to him that, yes, we have a lot of, philosopher, mentor, and supporters of the ivermectin in India. And I think you have endorsed that philosophy also. Thank you very much. And if you see repurposing of the drugs, so till date, there is no new discovery of the antiviral drug which can act against the COVID-19. Whatever the medication, majority of medicine, they have been used for the treatment and management of the COVID-19 till date in last 15, 16 months. They are basically repurposing of the drugs. Whether we have tried the hydroxychloroquine, which is basically an anti-malarial drug, and of course having some antiviral property also, that was the repurposing drugs. Remdesivir, which was basically working against so many other viral diseases, and against it was repurposed to the COVID-19. And similarly, azithromycin, doxycycline, ivermectin, a lot of things. So I think ivermectin also a repurposed drugs. And of course, the various 4 important properties, that is the anti-helminthic, antiviral, anti-cancerous, and immunomodulator. And of course, anti-inflammatory too, recently, just like Dr. Paul had mentioned. So I think with these properties, and one of the wonderful thing about the ivermectin is that it is the cheapest drug. So it can be a very important drug for the developing countries like India, number 1. Number 2, it's easily available. There is no question of availability. For example, when we used a lot of remdesivir gone from the market. So there was a lot of hoarding of course, remdesivir. And the third thing is that it is the most experienced, most tried drug throughout the world. For last more than 40 years, people have been using this drug for of course, as an anti-helminthic. So this is the most experienced drug, most safe drug. In last 40 years, we have not noticed any major side effect with ivermectin. And as Dr. Paul has mentioned in his presentation, that you can use the doses up to the 10 times of the usual dose. So that is the beauty. So I think if we want to use this drug in, of course, conjunction with the steroids for controlling the cytokine storm, you can increase the dose of ivermectin also. So I don't know what maximum dose of ivermectin we can use for controlling the cytokine storm or the viral application in the early phase. But I think a lot of clinical trials, Dr. Paul mentioned 56 trials. I was aware of only 40 trials. Now 56 trials are on till date. And in one of the important trials in All India Institute of Medical Sciences, Delhi, is going on with the 6 type of different doses. Will give the right answer that what should be the exact doses. The doses of 6 milligram per day, 12 milligram per day, 18 milligram per day, 24 milligram per day, 36 milligram per day, and even 48 milligram per day. So 6 type of doses trial, this is also going on. And I think result of that will tell you in our Uttar Pradesh, in my state, the largest state of India, which, of course, we made the protocol. I was the external expert for making that GO government order in Uttar Pradesh. So we have used the, of course, 150 microgram per kg of body weight and up to 60 kg, 12 milligram per kg. From 60 kg to 80 kg, it is 18 milligram per kg. And beyond 80 kg of weight, the 24 milligram. So that is our protocol, which we have made in our state. And I don't know, Dr. Paul can share the different views or various kind of views on doses of the ivermectin.
Yeah, so
can I make a quick comment?
Yeah, you ask a good question in terms of the dosing. So it's one of the questions which remains somewhat unanswered. So it seems for prophylaxis, you require a somewhat lower dose than for treatment. So it seems the sicker the patient, the higher the dose. So we have indeed increased the dosing for treatment. You know, we started at 200 mics per kilo. We're now up to 400 or 600 mics per kilo. So I think there are 2 important things: that ideally you should dose it by weight. And it seems that the dose for prophylaxis is less than treatment. And thirdly, it seems that multiple daily dosing is better than a single daily dose. But I think this is an area we still need to do, additional research. And it's good to hear that these studies are being done.
I just wanted to share some of our experience.
Yes.
As we talk, we are celebrating anniversary of ivermectin use in India. A little more than an anniversary. In last April, we started using ivermectin. When I am the chairperson of this IDF Southeast Asia, friends from Bangladesh told that they were using it. That time we started with a dose protocol of 12 milligram BID for treatment, twice a day for treatment for 5 days. Unfortunately, the first wave went and we were so overwhelmed with work that we could not publish our data. Now we are doing a proper RCT in treatment in mild disease with 12 milligrams twice a day for 5 days. Of course, that data will be in public domain. It's under peer review now, and you will see that data in public domain for 5 days. So I think there is a meaningful data. The per kilogram body weight dosing sometimes in India is challenging, and therefore sometimes of these doses are arbitrary. My question to Paul is that this prophylaxis. I saw one of your slides mentioning once a week prophylaxis. Correct me if I'm wrong. What was the biological basis for that, and how long will that be? Because you also almost made a passing remark that it could actually be a substitute for vaccination. And the second thing is that so you are into an Ivor club. Let me tell you that also. Suryakant is a good friend of ours, and we did a COVID I think webinar almost a year back. I think that also happened almost a year back. So a couple of things: that once a week, how long? Do you need it once a month? What should be the frequency? And would there be any deleterious effects? You see what happened, the WHO statement when it came out, they said and they signaled that it could have some deleterious effects, including immune suppressing effects. So is that just falsified information? Is there some truth in it? Can it have some immunomodulator potential? Can it have some dangerous sequelae? So, because when we have a drug, it's going to work, it's going to have good effects, and it's going to have adverse events. So could you give us some insights on that?
Yeah, so obviously that's a really good question. And the best data we have comes from Chile and Argentina, where what they've been doing is dosing once a week. So usually 12 milligrams once a week. They've done it for up to 10 weeks, but it seems you can do it indefinitely. The 1 week, so there are people who've done every other week or once a month. And it seems like the breakthrough rate is a lot higher if done bi-weekly or monthly. Part of the rationale for once weekly is that the ivermectin is actually stored in adipose tissue. So if you, in animal studies, if you measure ivermectin levels in adipose tissue, up to, 14 days later, there's considerable levels in adipose tissue because it's such a lipophilic drug. So the thought is that it's taken up by the lipid tissue and then slowly released. This becomes important because the concentration of ACE2 receptors is higher in adipose tissue than any other tissue. So the data we have really is once weekly appears to be the best. How long can you do this for? Well, we don't really know, but it seems for as long as SARS is a threat to the community. It's a very safe drug. And in order to prove its safety, you just need to go to the WHO's pharmacovigilance database. The WHO doesn't like to talk about this, but it's their own database in which they've collected adverse effects from ivermectin and every other drug in the last 25 years. If you look at their website, in terms of ivermectin, they list 16 deaths, and we actually know that none of those people who died actually died from ivermectin, and 4,000 adverse events. If you look at the vaccines for which we've been around only 2 months, the WHO website lists over 4,000 deaths and over 600,000 serious adverse events. So for the WHO to claim it's not a safe drug is completely dishonest and profoundly misleading. It's one of the safest drugs we know. There are very few contraindications. The only contraindication is it's not advised if you're less than 6 months of age because of immaturity of the blood-brain barrier, and it's not recommended in pregnancy. Although that's somewhat controversial, it's generally not recommended. Otherwise, it's an exceedingly safe drug. There are studies in which high doses are given for prolonged periods of time, and this is done for malaria prophylaxis. So ivermectin was being developed as a prophylaxis against malaria. The thought was that it would actually kill the Anopheles mosquito during a blood meal. So it's been given to people long-term in high doses, and it seems to be very safe. The best data we have to that question is from Chile and Argentina, in which they've given it for up to 10 weeks, and then they continue to give it. So, the question is how long? I think it's as long as you need to be protected against SARS-CoV-2. Once the baseline rate goes down, then you no longer need it. And, the WHO and the rest of the world don't want you to hear what I'm going to say. But you know what? It is a bridge to vaccination. And in those countries that can't vaccinate, it is an alternative to vaccination. But that's what Big Pharma, the WHO, the NIH does not want to hear from us. But it is a really good question. And what I would recommend is, people can review our paper, which American Journal of Therapeutics, where we actually detail the all the clinical studies for the treatment and prophylaxis. And the South Americans have done some very good studies using ivermectin for prophylaxis in many healthcare workers and shown it to be very effective.
Thank you, sir. Now let us move to our next question. So to Dr. Anup Kumar, sir. Sir, if I can have, sir, your comments on the uses of anti-inflammatory. Hello, Dr. Anup Kumar, sir. Yes, sir.
Yes,
Sir, your comments on uses of anti-inflammatory drugs in COVID-19, sir. So what is the correct way to use, like for example, sir, remdesivir is there. So what is the correct use of like favipiravir, for example, sir? So what is the correct way, sir, to our audience?
Among the antivirals, we don't have any strong evidence for favipiravir or other drugs. The only evidence, even though it is not very convincing, is for remdesivir alone. But as Dr. Marik was mentioning, you should know the pathophysiology properly. So where there is a viremic phase and when there is an inflammatory phase. So you have to use this drug properly, or you have to place this drug properly in the inflammatory phase, maybe like in the first 10 days. And again, we cannot use it for all the patients, like as per the like Act 1 trial and all. Like the patients who are requiring oxygen with severe pneumonia, I think still remdesivir is having a role. And the other all antiviral drugs, I don't think that there is enough evidence at present. So I think we can limit the use of remdesivir for selected group of patients who are having severe pneumonia and where we are able to use this drug in the initial days itself during the viremic phase.
Thank you, sir. So, sir, next question is for Dr. Arindam, sir. Sir, nowadays we are also hearing a few newer drugs like Beractinib and all, sir. So, sir, what is your point of view on all these newer drugs which are being used in COVID-19, sir?
Actually, for that you need to understand that what are the targets, that therapeutic targets for the newer drugs. We all know about the anti-inflammatory and antivirals. So if you allow me, I will just show two slides. Can I do that? So it would
Yes,
be
sir.
easier for understanding. So if you allow me,
Manmeet, Ritu? Ritu, can you just allow?
I'll just show one clear slide. I think I can share it now. Is my slide visible?
Yes, sir, it is coming. Yes, sir, it is visible.
Yeah. You see, this is the viral entry mechanisms and machinery. So you can target either to prevent the virus to enter this endocytosis. Then you can also target the S2 subdomains, right? So the way the macrolides and chloroquines and others do act. Some of the slides Marik sir has already shown, right? And this is the key elements in the viral replications where it can also be targeted, particularly in the replicative stage or the transcription phase. So if you see that if you subdivide this into, so you can prevent or intervene in the spike protein and AC2 binding sites, particularly the vaccines or the neutralizing antibodies or the ARBs and AC2 inhibitors act in that domain. You can target the main proteases, particularly some of the HIV protease inhibitors, that means the antivirals or HCV antivirals that has act. You can prohibit in the RNA-dependent RNA polymerase transcription, particularly the nucleoside analogs and the influenza inhibitors, as well as the zinc supplementation where it act. Or you can act into the entire virus itself, particularly the whole virus vaccine. Plasma, I won't say this had been acted well, but now the particularly neutralizing the viral neutralizing antibodies that have come, particularly the combination of casirivimab and imdemivib, those are working well. But also there is another way that where it can act is when the cytokine storm is happening, and the cytokine expressions are happening through the JAK as well as the STAT pathway, which eventually leads to the transcription of harmful proteins and the target genes. And this is downregulated by what we call the SOX itself. That means the suppression of cytokine signaling. So these are the areas where the JAK inhibitors or the STAT inhibitors or the SOX mimetics can act. So if you see, these are the areas which is very promising, right? So you can have a specific cytokine inhibitions like your tocilizumab or itolizumab, which are specific cytokine specific inhibitors, monoclonal antibody, or you can have the JAK inhibitors, and also there could be a JAK selective inhibitors or a non-selective inhibitors like baricitinib or tofacitinib, like that. And regarding your baricitinib, is that it has got an additional action on your preventing the endocytosis of the virus itself. So it has got a both way action of the JAK non-specific JAK inhibition, as well as the endocytosis. So I think this is an good way to deal with the cytokine storm, right? The specific monoclonal antibodies which might act against the specific molecules, or non-specific or selective JAK inhibitors. And as well as a lot of research has been doing where they are trying to find out whether it can be combined with the source mimetics, that means the signal transduction, to reduce the expression of harmful cytokines along with the JAK inhibitor itself. So it's a double therapy that people are looking at into. So a lot of trials are ongoing. These are the trials, baricitinib and the tofacitinib, and the results we will be awaiting. I think we might get a good response from this particular results. Yeah. Yeah.
Thank you, sir. Yeah. Thank you so much, sir. I guess we already got over time with our speculated time, sir. So, but still, because it was really a very good discussion and very good insights about uses of vitamin D3 and ivermectin we got, and of course the immunopathological issues with how to use remdesivir or baricitinib or maybe other new drugs which we can utilize for the COVID-19 management. So I thank you, Professor Paul, for sharing his insights and that useful information. And of course, our panelists, Professor Shashank Joshi sir, Dr. Anup Kumar sir, Dr. Arindam sir, and Professor Suryakant sir. So I thank you all on behalf of Mankind Pharma and Dr. Paul, of course, on behalf of Indian physicians, of course, I thank you, sir.
Thank you. It was a
Thank
pleasure.
you, guys. Thank you.
Thank you, sir.